This is for Pharmacology Module 2, Part D. The next set of medications that we're going to look at are actually medications for MS, multiple sclerosis. All right, let's talk about multiple sclerosis. So multiple sclerosis is a chronic disease. It's inflammatory and autoimmune. Okay, and your neurons have a myelin sheath that is covering them that helps to make neuronal transmission and protection of those nerves, right? And in that chronic inflammatory autoimmune disorder, either progressively or intermittently, demyelination occurs along that axon. And so conduction is slowed and or blocked, resulting in different deficits in cognition, sensation, motor activity. So all sorts of different neurological phenomena. The inflammation itself, the autoimmune portion definitely destroys the myelin sheath, but the inflammatory portion itself can destroy oligodendrocytes and axons. So it can destroy the nerve cells themselves as well because of the inflammation. There are multiple theories, but most of the theories for MS being triggered deal with exposure to environmental and or microbes that can initiate that autoimmune response and further autoimmune activity. There are 4 general MS subtypes: clinically isolated syndrome, relapsing remitting MS, primary progressive MS, and secondary progressive MS. With MS, we look at 3 types of reasons that we're using medications for. So 3 different therapeutic responses that we're looking for. One of them is we want to modify the disease process. Another one is that we treat the acute episodes. And the other one is treating the symptoms. Please remember that MS does not have a cure. The first set that we'll look at are the disease-modifying drugs. And there are 2 big classifications that we classify drugs into in the disease-modifying drugs for MS. There are the immunomodulators, and there are the immunosuppressants. The immunomodulators are safer, but the immunosuppressants take the immune system down even harder. So we generally like to start with safe, but if that's not doing the trick, move on to the immunosuppressants. patients with relapsing, remitting MS receive immunomodulators ASAP, absolutely ASAP, and then continues on indefinitely, okay? Some of the main concerns with immunomodulators are things like infections, opportunistic infections especially, neutralizing antibodies. So neutralizing antibodies means, I'll write it down here, antibodies. These are antibodies that eventually make the drug less effective. And then hypersensitivities. And hematologic problems, hematologic changes. Interferon beta is an immunomodulator that is used quite often. It is generally well tolerated. But a lot of people will get a flu-like reaction to it. Some people will get liver injury. Some people will have injection site reactions. And myelosuppression can occur. Please note that interferon beta sometimes comes as beta 1A and beta 1B. There is an IM form and there is a sub-Q form. Okay. What we really want to do with these is decrease the frequency and severity of the relapses and really take down that inflammatory and immune response. Before somebody starts this, we get a CBC with diff, so the full complete blood count with differentials, and then your LFTs, like your AST, ALT, Billy. We also want to know how the thyroid is working. So we might get a TSH, we might get a T3, T4. We will also get an underlying ECG, which if you're working with the common vernacular, people call it an EKG. With interferon beta, it is stored in the fridge. We do need to teach patients how to administer this to themselves. It is a priority to do that. And so we also instruct them when we're teaching them how to do it to rotate the injection site. The sub-Q is generally 3 times a week, and the IM version is once a week. The sub-Q version has some specific administration considerations, nursing administration considerations. So the sub-Q version is given preferably late evening or late afternoon, at least 48 hours apart. Okay. And then the person should choose the same days each week. So if they're doing Monday, Wednesday, Friday, they should continue Monday, Wednesday, Friday. It's better adherence if somebody's doing the same thing every week. With the flu-like reactions, they're common early in therapy and they do diminish usually. So they start low dose and then they increase a little bit. And they can take antipyretics like Tylenol or ibuprofen, acetaminophen or ibuprofen. Acetaminophen is the other word for Tylenol, just making sure everybody's aware of that. So we will be watching LFTs. We will be watching a full CBC to watch out for myelosuppression. And then especially with the subcutaneous injections, we should let patients know they should rotate the injection site. They can apply ice briefly after the injection. They can apply a warm, moist compress to reduce some of the itching. They can reduce persistent itching with diphenhydramine and hydrocortisone. But we often don't utilize those as much. Patients should know that the IM version can cause discomfort and bruising. When we talk about immunosuppressants for MS, mitoxantrone, and cladribine are the only immunosuppressants currently approved for MS. Okay? Mitoxantrone is immunosuppressing, so it's a little bit, it packs a bigger punch on the immune system than just an immunomodulator, but it's also more toxic. Okay, tox is even in the name. So the drug is generally reserved for patients if the immunomodulators aren't working or if the person isn't tolerant of them. The major side effects, the major adverse effects of mitoxantrone. Myelosuppression, cardiotoxicity, and injury to the fetus. So it is teratogenic. And as a person gets repeated doses of mitoxantrone, there is a lifetime accumulation that does occur in the body. And that's 140 milligrams per meter squared. And so there's a limit to how much can be used. And when that limit is reached, there becomes a huge risk of cardiotoxicity. It becomes very, very toxic. Mitoxantrone does give a blue-green tint. Okay, a blue-green tint to urine, skin, and sclera. And so patients should be alerted of that. Prior to somebody starting this, we want to do LFTs. We want an echo to determine the ejection fraction, left ventricular ejection fraction, to determine how well the heart is functioning. Always do pregnancy tests before giving it. And then also a CBC should be done. Okay. Okay, so high dose glucocorticoids. Generally given IV, are utilized in these very acute relapses. Okay. Also, IV gamma globulin. Gamma globulin can be used. MS can cause a variety of other symptoms. One is bladder dysfunction. Bowel dysfunction. Let's do dysfunction. Fatigue. Depression. Cognitive issues. Sexual dysfunction. Neuropathic pain. Ataxia and tremors. Spasticity. And dizziness and vertigo. Dalfampridine. Can be given to improve walking. Meclizine and Zofran can be given when people have dizziness and vertigo. Meclizine and Zofran. The other word for Zofran, the word that's actually the generic word that you would see on the NCLEX would be ondansetron. Okay. With spasticity, we'll talk about those later. ataxia and tremor. Relief can come from can also come from benzos, and primidone and propranolol. Neuropathic pain, sometimes anti-epileptic drugs like carbamazepine. Carbamazepine and gabapentin. Sometimes those can be used. With sexual dysfunction, sometimes antidepressants can actually be used. Sildenafil is one that can be used, especially with men. For some of the cognitive issues, sometimes the drugs given for Alzheimer's disease can be helpful. So things like donepezil and memantine. With fatigue, amantadine and modafinil are sometimes given. And then methylphenidate or Ritalin. Can also be given. Bowel dysfunction, we often talk about increasing dietary fiber and getting good exercise. Stool softeners can be used. Fecal incontinence, though, can be managed with both bulk forming fiber and also anticholinergic agents. With bladder dysfunction sits kind of in the area where we find sometimes anticholinergic drugs will work because they allow for relaxing of the detrusor muscle and allowing the bladder to fully empty. So some medications that can be used with this are tolterodine or Detrol, oxybutynin or Ditropan, and then also darafenacin or solafenacin. So those things are helpful. Sometimes alpha adrenergic blocking agents like phenoxybenzapine, tamsulosin, terazosin, those can help. So it all depends on what the problem is and what they decide the solution is going to be. Sometimes benthanacol or uricoline is given. So there are a lot of different meds that might be used that aren't solely focused on the actual progression of the disease or the relapses of the disease, but are focused on some of these secondary symptoms that happen once the nerve damage has occurred. And once the actual disease itself takes a toll on that individual. Since muscle spasms are really common with MS, and we utilize a lot of drugs for spasticity in people with MS, I'm going to move right along to the drugs that are used for muscle spasm. Okay. There's a centrally acting, and I put CNS because it's the central nervous system, and the central acting muscle relaxer is baclofen that we looked at. There's another centrally acting one, and so this one acts centrally, and cyclobenzaprine. And then there's one that directly acts on the muscle itself. And that one's called dantrolene, or Dantrium. So baclofen itself, the indication, this one's really good for spasticity, so spasms because of spinal cord injuries, or spinal cord damage. And so the spinal cord can often be damaged when someone has MS, having those neurons and the myelin sheaths affected. Cyclobenzaprine is great for musculoskeletal pain and muscle spasms. And then dantrolene is also really good with spasms because of spinal cord injury and or other CNS conditions. Okay. The adverse effects of baclofen include CNS depression, okay, dizziness, headache, nausea, vomiting, constipation, and then also urinary retention. Okay? When we're talking about cyclobenzaprine, we've got a few more things to add on to that. Here we've got CNS depression. We've got dizziness. We've got anticholinergic effects. Things like dry mouth, blurred vision, photophobia, urinary retention, and constipation. All right. When we go down to the dantrolene adverse effects, we're looking at muscle weakness. Remember, it's acting directly on those muscles. Drowsiness, dysphagia, and that's a muscular issue, right? Hoarseness, nausea, erectile dysfunction, diarrhea, and then a flushing that it can occur with IV administration. So make sure you follow those instructions very carefully. As we continue to talk about this, there are some implications for nurses, and these are administration considerations. So we've got to watch for hepatic toxicity with dantrolene. And negative effects can be associated with loss of function, so that has to exceed, the benefits have to be better than the risks. So with cyclobenzaprine, there is an extended release capsule that can be sprinkled into food but cannot be chewed. That's a very common theme with extended release. The contents are designed to be released slowly, right? So, administration with food increases the bioavailability. Okay. And baclofen we administer with or without food. Baclofen withdrawal is kind of a big deal. Baclofen doesn't really cause physical dependence, but an abrupt discontinuation can be problematic. And so, abrupt withdrawal of baclofen, they can have hallucinations, paranoid ideation, and seizures. So, psychosis and seizures. Rhabdomyolysis and multisystem failure can occur with the abrupt withdrawal of baclofen. Important things to know about dantrolene is it can reduce strength, it can be liver toxic, and it can cause dysphagia and hoarseness. One good thing about dantrolene is that dantrolene can be given to treat malignant hyperthermia. And this is a really good thing that it can be given to treat malignant hyperthermia. Malignant hyperthermia is something that can occur in surgery because of surgery medications and a person's likelihood of reacting to them based on either genetics or bad luck. Malignant hyperthermia is a metabolic crisis that is a really overwhelming metabolic crisis that's triggered by certain anesthetics or succinylcholine. And so dantrolene can be given for the treatment of malignant hyperthermia. Cyclobenzaprine is one that's given as this centrally acting skeletal muscle relaxant, and it is known to cause drowsiness. We talked about this before. Dizziness, fatigue, and it looks a lot, structurally, chemically, it looks a lot like a tricyclic antidepressant. And this is why it also, the body can mistaken it for something that can cause anticholinergic effects. In rare cases, There can be sinus tachycardia, and some conduction delays, especially in high doses. You cannot, and I repeat, if you're taking cyclobenzaprine, you cannot take MAOIs, okay? MAO inhibitors. So this can increase the likelihood of some things related to serotonin syndrome, and lead to hyperthermia, tachycardia, hyperreflexia, all sorts of different things that it can occur. So a recap of muscle spasticity is that NSAIDs, so we didn't talk about this before, but it is true. NSAIDs can be used with some of these centrally acting muscle relaxers, because we're getting pain relief too with some of the NSAIDs, and also that inflammatory response is taken down a little bit. Spasticity, usually treated with things like baclofen. Sometimes we use diazepam. Diazepam is one that we are going to talk about later when we talk about the benzodiazepines. Baclofen, diazepam, dantrolene, and a number of other drugs. We don't want to abruptly discontinue baclofen because of rhabdo and multi-organ system failure that can occur. We want to remember that dantrolene can cause fatal liver damage, and so we want to monitor liver function. Dantrolene, we want to remember, is something that we can use to treat malignant hyperthermia. So some general anesthetics and succinylcholine, whether it is genetic or whether it is bad luck. Some people have malignant hypothermia that ensues after getting those, and dantrolene is what is given when that ensues. Alrighty, there you are. There you are, you've got it. You've got medications used for MS and muscle spasticity.